And now it's my pleasure to introduce our speaker, Dr. Jordan Miller from Mayo Clinic. Dr. Miller is Associate Professor of Surgery, Cardiovascular Surgery at Mayo Clinic. And he comes to Mayo Clinic by way of Iowa, where he did his postdoc with Don Heistad, a famous vascular biologist, and they did some really interesting work in valve calcification that we'll hear a little bit about this morning. Actually, my understanding from Dr. Miller is that we have he's going to give us 2 talks for the price of 1 today. We're going to hear about his very interesting work with aortic valve calcification, of preclinical studies, and the clinical trials that resulted from that basic research. So a true translational effort, taking basic research insights and translating those into potential therapy that's now in clinical trial, the first drug for aortic valve calcification. And then we're going to hear about senolytic therapy, really a very interesting concept, and that is that the senescent cells are what make us sick, make us aged, and if you get rid of those, you get rejuvenated. And there's good evidence in animal models and some early evidence in man that Dr. Miller is going to be discussing. So anyway, thank you very much, Dr. Miller, for spending some time with us this morning. We look forward to hearing more.
Good morning. Thank you very much for the opportunity to come down here and present and talk about some of the work that we've done over the past several years. And so really, I think a lot of the talk is pretty chronological, and it tries to give you a little bit of framework about sort of where we've been, what we've tried to build as a program in terms of a translational research program, and then how we think this might be actually a scalable strategy to attack multiple diseases using multiple different targets. Essentially to attack age-associated cardiovascular diseases. And so if you look at the overall structure of my talk, what I'll go through is some of the foundational discoveries that we had over the past decade in heart valve disease, really focused on biology, but then also talk about a bit about the transformational grant that we'd received a number of years ago to accelerate the translation and use of soluble guanylate cyclase activators to treat aortic valve disease in clinical use. Then we'll shift gears a little bit and really sort of ask the question, well, is that strategy actually scalable? Is it applicable to other diseases or other targets, or is that just sort of a one-and-done approach to repurposing of SGC activators? We'll talk about a few of the preclinical studies that we've done of senolytics, and then ideally have a lot of dialogue and discussion at the end of sort of where are we and where do we really need to go to actually have this impact clinical practice and do so in an appropriate and safe manner. And so, about a decade ago, I ended up coming to Mayo Clinic from the University of Iowa, and I had a pretty simple goal, which I think most people do when they first establish their lab, which is, of course, A, stay funded, and B, identify some mechanisms using animal models, cell culture methods, and molecular approaches to identify mechanisms that contribute to valve calcification and aortic valve stenosis. And initially, we said, well, if we can continue that cycle for a good period of time and stay funded, then that's a great thing. And ideally, we'd start with valve calcification, and someday, I think, as everybody usually says when they're early on in their career, they say, well, it'd be great if we could impact human disease in some way, shape, or form. Usually, that takes quite a while to do. And so it wasn't on our immediate horizon, but we had initially started off focused really on nitric oxide signaling in valve disease. And it was largely directed based on our funding. And our real working hypothesis there was that with aging, you have losses in nitric oxide signaling. Those are permissive to this thing called bone morphogenetic protein signaling, which allows for induction of osteogenic genes and procalcific genes. And those permissive changes and those losses in nitric oxide signaling that occur with aging are really a key step that allows for valve calcification and disease progression. And so for us, that was our working model, right? And the reality is that it's a lot more complicated than that, as Dr. Cooke can attest to as well. There are plenty of precursors and modulators of nitric oxide bioavailability that have been identified. But what we initially started off with was really zooming in on this and saying, well, is there a way in which we can modulate this cascade, show using proof of concept experiments that nitric oxide bioavailability actually is a critical mediator of valve calcification, osteogenic signaling, and ultimately valvular stenosis. And so our goal was to alter activity genetically of this enzyme DDH1 here, which is a critical mediator of asymmetric dimethylarginine bioavailability, and that's an inhibitor of endothelial nitric oxide synthase. So our hypothesis is that if we alter the activity of DDH1, specifically reduce the activity of DDH1, that we could assess the biological impact down here and say, well, hey, maybe this will or won't alter progression of aortic valve disease and stenosis. And so we, in my lab, we use a pretty unique model of aortic valve stenosis. It's a hypercholesterolemic mouse model with a humanized lipid profile, so it's a LDLR deficient ApoB100 only mouse. And the real unique thing about this animal was then that we were able to cross that with mice that were deficient in DDH1 and ultimately modulate nitric oxide bioavailability and test our fundamental hypothesis that losses in nitric oxide were critical to accelerated progression of valvular stenosis. And so our approach was to start with the evaluation of phenotype and probe deeper then for molecular mechanisms. And from a high-level perspective, we had a couple of positive outcomes from this. One is that when we measure cusp separation distance, aortic valve cusp separation distance, you can see that when you lose one copy of DDH1, that you do have small but significant reductions in cusp separation distance, which are consistent with worsening of valve function. We have small but significant increases in peak transvalvular velocity. And from a very high level, we saw that losses in DDH1 or losses in nitric oxide bioavailability accelerated valve calcification, in that those accelerations in valve calcification were actually mediated and associated with increases in expression of osteoblast-like cells, which was really, again, sort of at the core of our hypothesis that valve disease, we think, is an active, regulated process. And if it's not, if it's purely a passive process, then there's not a whole lot you can do about that therapeutically. So we were excited about this, but at the same time, it's one of those things where you say, well, it seems pretty straightforward, but it's pretty complicated after you start looking at it for a while. And so in aortic valve, what we found is, of course, impaired organ function. So the valve was dysfunctional with losses in DDH1. We saw relatively conserved and synchronous changes in a number of osteogenic genes here. But when we evaluated these same changes in aorta, we really didn't see the conservation of complete canonical BMP signaling in aortic tissue. And so our interpretation of this was that probably in aortic valve, that failure of the valve and calcification of the valve was largely an osteogenic-like mechanism, and that in aorta, that these changes were more likely to be driven by a dystrophic-like calcification mechanism. And so we were looking at this and we were thinking, well, it's pretty complicated, and it's complicated further by the fact that nitric oxide signaling, it protects against valve calcification in our hands, but at least I think everybody would probably acknowledge that it's a tough nut to crack, and I think that's really actually complicated further by the fact that with DDH1 in particular, DDH1 is an intracellular enzyme. If you go and talk to any medicinal chemist and you say, I want to reactivate an enzyme, they would say, I'd really rather prefer that you go inhibit something. And so therapeutically, it's tougher with DDH1. And then similarly, if you're going to say, well, why can't you just give exogenous NO or some of these NO stimulators? It's really pretty complicated, right? So exogenous NO, it's a vasodilator. Most of the SGC activators are vasodilators. It's very difficult to get things to reach tissues intact, and in many contexts, there's development of resistance to NO agonists, and so you say, well, what do you do at this point, right? And at that point, I kind of said, well, we should just cut bait, right? And we should just stop, and that is driven in large part by the perception of therapeutic futility. But is also driven by, of course, the utilitarian perspective that we just got another grant to study epigenetic regulation of gene expression. And so we said, well, all the stars are aligning for us to shift gears here. And so usually right when you say, well, we should shut everything down, that's usually when another door opens, just to show that, you can be wrong a good amount of time, but lucky it's a good amount of time as well. And there was a new funding mechanism that came out from NIH called New Therapeutic Uses for Existing Drugs mechanism. And this was essentially, it's a 1-year proof of concept study where at the UH2 phase, you were required to do all of your cell-based work, all of your animal work, and actually dose your first patient for a phase 1 clinical trial in your first year. And in the second 2 years of this, which is the UH3 phase, you had to execute a phase 2 clinical trial. And you say, well, that sounds difficult enough by itself. But then on top of that, they said, well, you can only pick from 30 drugs that we have, right? These drugs were provided by pharma partners. They had to have a known safety profile, known formulation. And that was about it, right? And they had to be actually terminated for development with pharma. So really a salvage pipeline here. So statistically, you'd say, well, what are the odds that one of these 30 drugs, of all the thousands of drugs that are out there, would actually hit our target, right? And it's actually incredibly low. But the reality is that about 2 weeks before the deadline for the letter of intent, I looked through this one more time, and I saw this compound HMR 1766, and I said, well, I don't know what that is. And I clicked on the link, and it says atosiguat, and I said, oh no, everything that ends in iguat usually is a SGC activator, which aligned perfectly with our pathway. And we had 2 weeks to put together a letter of intent and submit our grant on that. So now, if you recall, so our working hypothesis here, you lose nitric oxide. That's a permissive mechanism to activate canonical BMP signaling SMAD translocation to the nucleus and drive valve calcification and disease. But now we're saying, well, if we provide an SGC activator, can we actually stimulate SGC, restore nitric oxide signaling, and prevent this cascade of events that we think is really driving valve calcification and stenosis? And again, I think the most important part about this compound is actually that it's not stimulating the healthy form of soluble guanylate cyclase. It actually only selectively stimulates oxidized or heme-free soluble guanylate cyclase. So it's only stimulating SGC in regions where there's substantial disease. And for us, we said, well, hey, in the valve where you've got a rock of calcium next to some soft tissue being thrown back and forth 60 times a minute, that's a beautiful microenvironment for this to act. And so it really caused a paradigm shift in the goals of my lab, where initially we said, well, it'd be great for us to go around and around in this circle of discovery. But now, our goal was really to say, well, how can we catapult this forward therapeutically towards patient application in patients and have that catalyzed by this opportunity to repurpose atosiguat? And so in line with the mechanism that was proposed by NCATS, we had a multi-phase approach. So in our first year, we did rapid proof of concept studies. Now, the NIH mandate was that you couldn't do substantial mechanistic inquiry. You could only do molecular studies sufficient to demonstrate proof of concept. So we had a few cell experiments and mouse experiments, and at which point we were obligated to dose our first patient by the end of the first year, which we did. And then we moved on to the UH3 phase, which was a phase 2 clinical trial, and to demonstrate efficacy. And so what I'll do now is I'll just summarize some of the key findings that we have from this study. And so we initially had worked with some investigators up at the University of Minnesota to develop an SGC-based assay that would allow us to just confirm that atosiguat did what we thought it was going to do. And so you can see here that with increasing doses of atosiguat in a biochemical assay, that when you have this heme-deficient soluble guanylate cyclase that's most evident in diseased areas of the body, that atosiguat is actually most efficacious at activating the enzyme there. It's less effective at activating oxidized SGC, which again only present in diseased tissues. But then with this reduced SGC, which is present under healthy conditions, it doesn't really do a whole lot, which played to our advantage in a major way, because when you reactivate SGC signaling, specifically with robust activators of reduced SGC, you have vasodilation and hypotension, and that's generally not sustainable for a therapeutic strategy. So we said, okay, well, it does what we wanted to do biochemically from a cell type specific perspective. Atosquat did effectively activate SGC in valve interstitial cells in vitro. So we played it out in mouse valve interstitial cells as well as human valve interstitial cells. And with increasing doses of atosquat, we had increases in phosphovasp levels, which is indicative of SGC activation. And so we ended up using 1 micromolar for all of our in vitro experiments at high concentration, but consistent outcome. And we said, okay, so we get biochemical activation, we have cell-based activation that appears to be reasonable of our target of interest. So now, does it actually attenuate osteogenic signaling in vitro? And so we treated cells with increasing doses of atosquat, and as you can see here, we have dose-dependent reductions in osteogenic signaling. So again, it's consistent with repression of this pathway that we think is critical to driving aortic valve disease. And similarly, we showed that atosquat effectively abrogates exogenous BMP2-induced canonical BMP signaling. So again, very consistent with our working hypothesis. And you say, well, that's great from a cell-based perspective. Well, what about in vivo? So we used a therapeutically relevant study design with 2 groups of hypercholesterolemic mice. One was fed Western diet for 9 months. The other was fed a Western diet for 6 months, followed by a Western diet plus atosquat for 3 months. So the mice have mild to moderate valve disease here at the 6-month time point. And of course, if you think back mathematically, if you only have a year worth of time to get to phase 1, and we spent 9 months of that actually doing the preclinical studies. We did take a leap of faith and put all of our animals on diet about 6 months before our grant actually came in. So we would have been either dramatically overspent or very, very well off. And so that was our strategy to make sure that we could get that done in the first year. And essentially what we found was in line with our working hypothesis was that with a physiologic dose of atosquat, that we get activation of SGC in vivo in these mice with advanced valve disease. It's in both male and female mice. So we get an induction of phosphovasp serum 239 levels. We have successful suppression of osteogenic signaling in vivo. So again, this is phosphosmad 158, the key mediator of canonical BMP signaling in both males and females, so a conserved mechanism there. Reductions in osteogenic markers in both males and females, so expression of RUNX2, expression of osteopontin, both of which are strongly associated with ossification of ectopic tissues. Both of those were significantly reduced in males and females by atosquat. And concomitantly, we also saw reductions in valve calcification. So it wasn't that we were just altering some things molecularly, they actually translated to something that was reasonable histopathologically. Now, the ultimate moment here was when you analyze the echocardiographic data. And so there, when we measured cuff separation distance, which again we think is probably the most robust way to assess valve stenosis, we found that in male mice that there was significant preservation of valve function with treatment with atosquat. So you can see that here, that there's an increase in cuff separation distance consistent with the valve opening better. Whereas in female mice, there was actually no significant impact on valvular stenosis, which was surprising to us given all the histopathological data that we had leading up to that. Similarly, when we evaluated diastolic function in mice, we use EE prime as a measure of diastolic dysfunction because some measures like EA ratio don't work too well with physiologic heart rates and EA fusion. What we found was that in male mice, again, atosquat improved diastolic function in these mice, but in female mice, there was no phenotypic benefit. So there, I would say, just as a sort of summary up to this point, in these preclinical studies, atosquat looked pretty promising from both a molecular and functional perspective, and it was a little bit anticlimactic from a sex-dependent perspective, but at least we felt that we had a sufficient data to move forward with our preclinical studies. And so From a phase 1b safety perspective, we're pretty fortunate that I have nothing terribly exciting to report, so I could go through the data, and there's really not a whole lot there, but Atosquat is well tolerated. It doesn't induce hypotension, and it doesn't increase liver enzymes. And so after those studies, we moved on to the phase 2 study. And so this is really, where the rubber hits the road, right? So we had a randomized, double-blind, placebo-controlled trial with up to 1 year of follow-up. Our primary outcome variable now it was aortic valve calcification. Secondary outcome variables were valve function and ventricular function. And I think that really one of the critical components of this was actually our trial design, which we had leveraged our clinical colleagues' insights quite substantially on. And so for our inclusion criteria, patients had to have a valve area between 1 and 2 centimeters squared, which is really mild to moderate aortic valve stenosis. Had to have a tricuspid aortic valve, so couldn't have a bicuspid valve. Had to have preserved left ventricular function, but at the end of the day, our major inclusion criteria that was critical, I think, for the success of the trial was that you had a valve calcium greater than 300 units by CT scan. So we know that from historical data that if the patients have greater than 300 units of valve calcium on the valve, they're much more likely to progress. If it's less than 300, they're much less likely. And so this is sort of when you unblind at the end of a couple of years, this is what you hope you see. So when we did our final data analysis, essentially what we found was that treatment with the Atosquat, this is over a 6-month period here. The vast majority of our patients completed 6 months. We have approximately a 70% reduction in progression of valve calcification. Again, patients with mild, moderate aortic valve stenosis. Interestingly, and with an almost exact parallel to our animal model, this effect was predominantly evident in males and females. Although progression was also slower, there really wasn't much of a phenotypic benefit at all in patients. And so when we importantly evaluated bone mineral density throughout, so we used DEXA scanning at all time points. Importantly, Atosquat doesn't negatively impact bone mineral density, so it's not as though you'd say, well, we stopped calcification of your valve, but sorry, you have severe osteoporosis. Bad deal there. So we're happy to see that there's no impact here. And similarly, we were even surprised to see even a tendency towards a slower progression of valvular dysfunction. At a 6-month time point, we were just thrilled to see any trend there. So at this point, we were very happy, but at the same time, we were curious about the sex differences that we had seen. And so what we actually did is we had one of our data scientists at Mayo go back and use a non-biased analytical method to say, well, what are the real determinants of progression of valve stenosis in patients with our trial based off of baseline parameters? And the interesting thing was that when you go back and use a neural network approach to analyzing the data, is that right in the corner here you can see that the first 2 things that are most predictive of you having a change in valve calcium over time were, first, what treatment you received, which I was very happy to see. So if you received Atosquat, you were less likely to progress. Second, the interaction with sex. So if you were a male that received Atosquat, you were likely not to progress. If you were a female that received Atosquat, you were more likely to not receive therapeutic benefit. So again, using a non-biased approach to really identify who you would want to have in a larger trial prospectively and how you'd structure those trials appropriately. So there, I would just say, from the view from 50,000 feet, that's what we aim to do. That's what we aim to do on a regular basis, is bring things from this discovery base to phase 1, phase 2 clinical trials and really demonstrate proof of concept. And the optimist would say, that sounds really fantastic, right? And that looks like a great research model. At least that's what I tell myself every day when I wake up, right? And but the pessimist would say, that's nice, but you're a really lucky guy, right? And I wouldn't disagree with that either, right? But really, it brings up a really important question, right? Which is, how scalable is this model, right? And can we actually leverage this repurposing or repositioning a model to accelerate progress towards other indications? And so what we wanted to do to really vet this thoroughly, was to say, well, if we take completely different targets, completely different drugs, in largely a different framework, different working model. Is there a way to accelerate the rate at which we can bring novel solutions to patients with unmet needs? And so it was right around this time that this area of senescence started to emerge. And so senescence is essentially this concept where as we're aging, there's the accumulation of these cells that are, people refer to them as zombie cells or whatnot, that the senescent cells, they end up accumulating throughout the body where they are functionally cells that prevent the division of cells with DNA damage. So the issue here is that when you're young, you can actually clear these senescent cells pretty effectively. You develop a genetic mutation or you have some DNA damage, the cell becomes senescent, it stops dividing, the immune system comes and clears those cells out, and everything goes along fine. The problem is that with aging is that, that there's this reduction in immune cell function, and these cells are cleared less effectively. So now you start to have accumulation of senescent cells, and the accumulation of these senescent cells is sort of at the core of the working hypothesis that this can have a deleterious effect on multiple diseases. And so we know that when you look at multiple diseases that are associated with aging, they're all the sort of big, problems that we face societally, with frailty, heart failure, osteoporosis, stroke, vascular disease, on and on. And it's a very exciting hypothesis to say, well, if you could remove these senescent cells pharmacologically, would that be a viable strategy to prevent some of this multimorbidity? And so when we start to look at the biology of senescent cells in a little bit more detail, you can see here that as we age, with cell division, if there's telomere shortening and dysfunction, DNA damage, genetic factors, oxidative stress, all these things can induce cellular senescence. And these senescent cells, they don't just sit there and do nothing. Right? They actually have this thing called a senescence-associated secretory phenotype that promotes inflammation. Now that in and of itself is actually not a bad thing, because when you have a cut on your hand, the induction of cellular senescence is critical for driving fibrosis and wound healing and tissue remodeling. But when they're chronically there in places where you don't really want them, then the thought is that these increases in senescent cell burden are going to be accelerating atherosclerosis, coronary artery disease, aortic valve disease, and other pathologies associated with aging. So for us, this really drove us to develop some new collaborations, because we had content area expertise in cardiovascular disease, but not necessarily the domain expertise in senescent cell burden. And so in our Kogod Center on Aging, Jim Kirkland and Tamara Ciconia have really been two fantastic collaborators for us over the past several years in this space. And what they had done actually shortly after we had moved downtown was to the Guggenheim building was to use transcriptomic approaches to identify these pro-survival pathways in senescent cells that make them just sort of hang out and stay around for a long period of time after induction of senescence. And so their goal was to say, well, if we use selective siRNA screening and drug screens, can you identify something that would actually be able to kill senescent cells? And so at the core, when we start to talk about these drugs called senolytics, you say, well, biologically, why are these senescent cells so persistent, right? And the problem is that they have all of these pro-survival pathways that are hyperactivated, right? So they're creating a lot of inflammation, but they're also surviving really well in that inflammatory environment. And so our working hypothesis was that, well, if we targeted some of these things, some of these pro-survival pathways, if we started to inhibit these pro-survival pathways, would these cells actually functionally kill themselves, right? Because now they don't have hyperactivation of those pro-survival pathways. And so in 2015, we actually published with Jim the first evidence of senolytic drugs in aging cell. And there we used two drugs, a combination of drugs, dasatinib plus quercetin, which we viewed as sort of two repurposed compounds. And for us, the key finding in those studies was that senolytics not only improved multiple age-associated phenotypes, so this was sort of the very broad strokes phenotyping of a number of things, but we were really most interested in nitric oxide-related signaling. And so here we've got responses to acetylcholine, which are indicative of endothelium-dependent function. So you can see that treatment with dasatinib plus quercetin, importantly, in 27-month-old mice, they were treated once a week for 3 months, right? so they were already substantially aged. You can see here that this intermittent treatment regimen actually significantly improved the responses to acetylcholine and also substantially improved sensitivity to nitric oxide donors like sodium nitroprusside. And so, our big question at this point was, well, that's great, but other than just chronological aging and pristine aortas from old mice without hypercholesterolemia, can we actually treat and effectively ameliorate vasomotor dysfunction and established cardiovascular disease? So initially, what we used were ApoE deficient mice. We allowed them to develop established plaques, and then we initiated treatment with dasatinib plus quercetin. And so this was with a 4-month treatment regimen of just Western diet, followed by 2 months at the end once they had established atherosclerosis with either vehicle or dasatinib plus quercetin. And so initially, we asked the question, can we actually get rid of senescent cells in atherosclerotic vessels? And the answer is well, sort of. When we evaluated these telomere-associated foci in the vessel media, we found that, at least in the vascular muscle wall, that we found substantial reductions in senescent cell burden. When we evaluated the plaque itself in the vessel intima, we actually did not see efficacy of the drug to clear senescent cells, and that's largely depicted here. And so, to the trained eye, you'll just have to trust me that that's reflective of the mean data here. But when we evaluated vasomotor function, again, it was a little bit anticlimactic insofar as responses to acetylcholine weren't substantially improved by treatment with dasatinib plus quercetin in this established disease, but we were able to show that there were substantial increases in sensitivity to nitric oxide donors, which again was very consistent with the pattern of senescent cell clearance that we saw in these mice, right? So that we only saw senescent cell clearance in the vascular smooth muscle layer. Being calcification-centric, we also said, well, do we attenuate vascular calcification? And importantly, we were able to show significant reductions in calcium burden in vessels from these mice. And again, this occurs despite sustained severe hyperlipidemia, right? So we were pretty impressed that we actually saw anything at all. And again, this occurred concomitant with reductions in expression of genes associated and proteins associated with osteogenesis. And maybe to sort of close the loop here, when we evaluated plaque size and lipid content, we actually didn't see any impact of dasatinib plus quercetin on the actual plaque or lesion size. It was predominantly an impact on vascular function, plaque composition. So to us, we said, well, this actually looks like it's lining up for something that would be a combination therapy. And so when we started to look at, maybe at a summary here of what we found to date, so when we repurposed senolytic drugs for treatment of cardiovascular disease, I think it's safe to say that we can reduce senescence markers of senescent cells in blood vessels. We can improve vasomotor function. We can reduce vascular calcification. We can't really do a whole lot to plaque size as a monotherapy. But overall, we thought this looked pretty promising and warranted future investigation. And so, and importantly, these studies were really focused largely solely on dasatinib plus quercetin in singular outcomes of vascular function and histopathology. So we next wanted to ask the question, well, if we take what we would view as a better model, right? Can we ask the question of, can senolytic therapy actually predict or prevent multimorbidity and multiple cardiovascular morbidities in a model that we feel is more viable for prediction of clinical efficacy? So again, now we return to our humanized mouse, this LDLR deficient ApoB100 only mouse. We started our analyses in aorta. But now we not only had the interventions of course, vehicle and dasatinib plus quercetin, but we also tried a new drug called fisetin, which is a flavonoid, which looked very promising in vitro studies for clearing senescent cells and performing as a senolytic. And so when we said, well, what happened in aorta, right? So I would say broadly, senolytic efficacy in aorta is pretty poor. right? And so if you look at P16 expression or CDKN2A, unlike what we saw in ApoE mice, we really weren't able to see any substantial reductions in P16 expression. And we're in the process of trying to nail down, well, are there certain cell types in which it might be more efficacious or not? But overall, second model was not as impressive as we had hoped. Similarly, when we looked at endothelial function, really didn't see a whole lot here in terms of improvements in endothelial function. Maybe to the trained eye, we'd have a significant, but statistically significant, but physiologically insignificant improvement in endothelial function. Really not an improvement in sensitivity to nitric oxide. No improvements in vascular smooth muscle spell contraction. So here, or very subtle improvements in vascular contraction. So here we said, well, this has been, pretty expensive venture, right? But somewhat anticlimactic. And we said, well, fortunately, this actually is a very good model, again, for aortic valve stenosis. And so we asked the question, well, does dasatinib and quercetin or fisetin, do those reduce senescent cell burden and attenuate progression of valve disease in these models? And so now when we evaluate P16 expression, again, this is just mRNA levels in whole tissue, what we found is that fisetin was actually rather effective at reducing senescent cell markers in aortic valve tissue. And similarly, we found significant increases in cusp separation distance in these mice that were associated with reductions in expression of markers of osteoblasts-like cells in the valve. And similarly, as I mentioned before, these cells express this senescence-associated secretory phenotype. And there, a big component of that is TNF-alpha, driving inflammation. And again, fisetin significantly reduced TNF-alpha levels in aortic valve tissue from these mice. And so there we said, well, okay, so from an atherosclerosis perspective, it's maybe a little bit more complicated than we would hope. From an aortic valve perspective, it actually was looking very promising. But, for atherosclerosis, we wanted to then ask the question, well, we know that we're intervening in mice that are severely hyperlipidemic. And I think for all the clinicians here, if somebody came in with severe hyperlipidemia, you wouldn't say, well, we'll just leave your hyperlipidemia alone and treat only your cellular senescence. No, you would say, well, we'll put you on a lipid-lowering therapy and potentially consider combination therapy. So there, the question that we had clinically, was can Senolytics synergize with lipid-lowering interventions in hyperlipidemic mice? Scientifically, we were asking the question, is there a critical and permissive context that enables senolytic drug efficacy? And so we used, again, this backbone of a hyperlipidemic humanized mouse, but now it's a little bit more complicated. So this mouse was actually generated by Steve Young, where they have the microsomal triglyceride transfer protein floxed by LOX-P sites and an MX1-dependent CRE that allows for the administration of a compound called polyanesthetic polycitidilic acid, which drives CRE, cuts out critical portions of the MTP gene, and ultimately allows us to genetically lower lipids in these mice, which was an incredibly clever way that Steve had developed to do this. But again, it allows for actual functional lipid lowering in mice. And so what we did is we asked the question, well, if we can concomitantly administer intermittent senolytic treatment with robust lipid lowering, what happens to senescent cell burden and vascular function? So if we look, sort of work our way backwards from phenotype down to molecular mechanism, you can see, again, with vascular function, we're not really seeing a whole lot with endothelial function, improvements in endothelial function. We're really not seeing a whole lot in improvements with responses to sodium nitroprusside or NO donors. So again, you're really sort of hitting a brick wall with regards to substantial improvements in vasomotor function in this model. We did, however, find that this combination therapy was actually synergistic with regards to reducing senescent cell burden. So you can see here that with Western diet alone, we have tremendous increases in senescent cell burden. With lipid lowering, we do get a reduction in senescent cell burden, but that's significantly augmented by concomitant treatment. And this is intermittent, once every 2 weeks treatment with fisetin. So we're thinking that we might be able to optimize this further by augmenting the frequency of treatment with fisetin. Furthermore, when we evaluated expression of RUNX2, we see changes in RUNX2 that are consistent with this linkage that we had observed before between between senescent cell burden and osteogenic signaling. And so, so again, profound induction of expression of osteoblast-like cell gene expression with Western diet, not significantly attenuated by lipid lowering alone, but is augmented by this combination treatment of both senolytic treatment plus lipid lowering. So for us at this point, we'd say, well, I think it's a tremendously exciting time for translational research, and I think if we take sort of everything that I presented collectively here, what we're doing is we're laying the foundation for a phase 3 trial of atosigod. I think taking a multi-center approach to doing that is going to be a very exciting, hopefully advance for patients with aortic valve stenosis, particularly at a time where their sole treatment options are either open surgery or TAVR. And so we're excited to see whether we can actually bring this to clinical utility. With senolytics, I think the biggest question that we've got on the horizon here is, are senolytics actually a viable therapeutic strategy to slow progression of cardiovascular disease in the future? And I think the short answer is yes, and the longer answer is yes, but it's complicated. The big questions that are out there, right, is that what drugs are actually efficacious senolytics, right? Is there a really broad senolytic that works on all cell types? If there is, we haven't found it, right? But if there's not, then what are the cell type specific senolytics that need to be used in certain patient populations to demonstrate clinical efficacy? And furthermore, what are the clinically relevant contexts in which these drugs might actually demonstrate efficacy, and how do they work either with a monotherapeutic approach or in combination therapy? We've got a lot of additional data here in the space of senolytics that would suggest that it's not just as simple as putting this on top of lipid lowering to get efficacy in all tissues. And so it is I think, scientifically a fruitful area for investigation, but also has a tremendous clinical relevance. And so in terms of where are we going with senolytic therapies, I mean, we are gearing up to launch a phase 1 and phase 2 clinical trial series in the near future, ideally in 2020, for the use of senolytic drugs. We think that in the context of vascular calcification and aortic valve calcification, and certainly with some data related to diastolic dysfunction, that we do have sufficient data, at least phenotypically, to warrant initial exploration of safety and efficacy trials. And these trials really being focused on multiple endpoints related to cardiovascular function. And for us, I think what we learned historically is that it is instrumental to obtain clinical insights from our clinical colleagues, right? What are the diseases that are most likely to yield success? And on top of that, you can say, well, if there's a patient population where you might actually yield success, what is that sweet spot in which you need to intervene? What patients are going to progress, what patients are not going to progress? I think it's extremely complicated, and if we knew every heart failure patient that was going to be readmitted, I think it would really actually be pretty straightforward to design trials to address those patient subpopulations. But it is complicated to say who is going to progress, who's going to have events. And finally, of course, the challenge that we face with senolytic treatment in particular is what are the biomarkers that we could actually use to demonstrate drug efficacy? Because there's been a lot of work done to say, well, can we clear senescent cells in the tissues that we can access, adipose tissue, or skin, or other tissues that are easier to access? I don't think too many people would line up for aortic biopsies, right? And so how do we design those studies? How do we leverage studies from tissues that come out from patients that are undergoing bypass surgery to identify what biomarkers and what drugs are efficacious to clear senescent cells in certain tissue subtypes? So overall, for us, we've said, well, I think that we have identified some strategies to accelerate the rate at which we can move from bench to bedside. And overall, it does require, I think, a very new strategy for us, certainly, which is definition and establishment of multidisciplinary teams out of the gate, and really designing your preclinical studies with the intent of having them be translationally oriented. Of course, it requires detailed biological and clinical insights into disease specifics. And so one without the other really disables the ability to move from bench to bedside. For us, we've been extremely fortunate to have a large number of partners that have worked synergistically to advance this, and one of which, a major one, was Sanofi, who had provided the drug for our repurposing studies, which is a tremendous advance. And again, that new and faster strategies to move ideas towards clinical availability, which would include advocacy with the Food and Drug Administration. So again, I would say that we've been heavily reliant on team science. I think if you ask most of the people in the lab what I do, they would probably just say subsidize. And so we've got a tremendous group of people that have done a huge amount of work to make this a reality. And we've been very fortunate to receive a good amount of support. And so with that, I look forward to any questions, discussion that you'd have. Thank you for the opportunity and your attention.
Thanks very much for that, Dr. Miller. I do have a comment and then a question. I've seen your colleague James Kirkland present on his work with senolytic drugs, quercetin and dasatinib.
Yes.
The two combination. The preclinical data is compelling, and then he has some early clinical work. For example, the diabetic patients with adipose tissue. Take adipose tissue from a diabetic, you see a lot more senescent cells in the adipose tissue, and that with his treatment, the dasatinib quercetin, those can be cleared with an improvement in insulin sensitivity. And I was wondering, based on the clinical work, what trials are going on currently or planned with that senolytic regimen?
Yeah, so I think right now, we do have a number of trials that are being initiated, largely in this sort of phase 1, phase 2 admixture, if you will. We do have a trial ongoing with idiopathic pulmonary fibrosis to determine whether dasatinib plus quercetin can improve either lung function or physical activity in patients with idiopathic pulmonary fibrosis. Certainly, from an adipose tissue perspective, it's a very attractive strategy because insulin resistance of adipose tissue is a major contributor to dysglycemic regulation. And so LaTanya Hickson is driving a series of studies and clinical trials focused on assessing the efficacy of dasatinib plus quercetin in patients with diabetes-associated nephropathy. Again, really saying, can we eliminate or certainly substantially reduce senescent cell burden in adipose tissue, and then subsequently see clinically meaningful changes in renal function over time? So those are the kind of the two big ones. I think we're still at a stage where we say, well, if you clear senescent cells in adipose tissue, that's probably a good thing, right? But from a cardiovascular health perspective, nobody wants to follow anybody for the next 15 years to see whether that manifests as something clinically significant. So then how do we identify what endpoints are viable to predict optimal cardiovascular health downstream? And using non-invasive measures like non-invasive measures of endothelial function like endopat or echocardiography, things like that. We've been trying to add those as ancillary sort of secondary, tertiary outcomes to a lot of the studies that are going on, just to say, well, if we broadly reduce senescent cell burden in a number of contexts, is there evidence for this fundamental role of senescent cells in cardiovascular health? And I think it really is going to be that mountain of data that will support efficacy in cardiovascular disease and multimorbidity over time. Yeah.
So my name is Steve Little. Thanks, Dr. Miller. That was a really nice talk. Changing gears from the therapy to maybe understanding the pathobiology a little better from a clinical perspective. So we know that the left-sided valves clearly calcify much more than the right-sided valves.
Right.
5 times the pressure, roughly, on the left side. So what are the signals with the mechanobiology of why do we get calcification in relation to pressure differences on the left? And in particular, in the bicuspid setting, that whether you have abnormal flow, non-laminar flow, they tend to calcify 10 years earlier. What do we know about those signals? And then I have a follow-up question regarding TAVR.
Right. So okay. So yeah, I'll start with the first one. First because famous last words. That's the easiest one, which is that most people don't study the right-sided heart valves, sort of regardless. And the studies that we've done actually historically, with just ancillary measurements of molecular readouts on the right-sided heart valves. Whether you infuse with angiotensin II, take a hyperlipidemic mouse and assess right-sided heart valves, again, similar to what you see clinically, you don't see actually a whole lot going on the right side of the heart. And so whether that's a pressure difference issue, whether that is a blood oxygen tension issue, whatever, I'd love to say something super insightful on that front. I would just say that it's it's pretty poorly understood. And again, I would say it's almost, in many ways not driven by, the clinical problem, right? And we might actually be attacking that the wrong way, where you'd say, well, could we identify therapeutic interventions based off of the resistance of the right side of the heart, right? And I don't think we've really been thinking about it that way. And that's a great question. In terms of pathobiology versus, the bicuspid versus tricuspid valve. Bicuspid one has been a really elusive, I think, mechanistic odyssey in a lot of ways. There have been a handful of studies that have really strongly implicated notch mutations in bicuspid valve formation and accelerated valvular calcification. I think in large populations, those really haven't borne out as being, core conserved mechanisms. And so the way that I have generally thought about it has been that that in most of these patients with bicuspid valves, there is generally disinhibition of some osteogenic signaling cascade. And even though, a lot of people would say, well, there's not bone in all these valves, I would say that, that doesn't mean that there's not osteogenic signaling and there's not procalcific signaling evident there. And so do I think they're different between bicuspid and tricuspid valves? I do. When you evaluate, senescent cell burden, for example, in patients with bicuspid valves and aortic aneurysm, and you evaluate the aneurysm in tissue versus patients with tricuspid valves that are older with thoracic aneurysm, senescent cell burden is definitely higher in patients with tricuspid aneurysm. So it looks like the bicuspid aneurysm might be driven by a different mechanism, maybe not so heavily reliant on senescence. And so, for us, like if I was going to say, what would I do, right? I would say that patients with bicuspid valves, in many ways, I think that a tosagouat should be a viable therapeutic strategy to slow progression of valve calcification and delay the need for valve replacement surgery. Certainly, I think the longer you can delay a TAVR, longer you can delay a replacement in these patients, the better off they're going to be. Senescent cell burden, my knee-jerk reaction would be that, as these patients start to get higher in age, if you're the fortunate, 60-year-old with a bicuspid valve that has just mild, moderate AS, I would say that's probably a good patient who would be a candidate potentially for combination therapy with a tosagouat plus a senolytic. That might be the optimal strategy to do that. But it's maybe a roundabout answer to maybe what you were asking, but hopefully, somewhat helpful, right?
Dr. Miller, thank you for that great work and great talk. I have a two-part question. One is just a straightforward, I don't know if I missed it. When you're looking at the SGC and then your focus on the calcification concept, do you know what cells play a role in the valve tissue?
So our thought is that it's the valve interstitial cells. It's predominantly the resident cells that are there that are redifferentiating to an osteoblast-like cell phenotype. We've done some tissue-specific knockouts of progenitors for valve interstitial cells, and those cells do have the greatest propensity to undergo osteogenic differentiation. It's not to say there aren't some circulating cells that might also come there and participate and contribute, but my dog in the fight is the resident cells.
And that leads to, when you look at concepts of aging, fibrosis, and we're dealing with that in heart failure, John and I have some collaborative work, there's this concept and threshold of adaption versus maladaption. And it almost is that an organ gets a dysfunction, you trigger a reaction, which typically is probably engineered to be an adaptation.
Yeah, yeah.
But then it becomes a maladaptation by either a perpetuation of inflammation and other contributors. When you're devising a therapeutic approach which is targeted, I almost sometimes feel we're simplifying biology and fooling ourselves that it's going to work. So how do you factor that complex mechanisms and pick the right place and right point?
Yeah, I think you're hitting the nail on the head, which is, you want to make it as simple as possible, but no simpler, right? And I think in many ways, everybody's, it goes up and they say, well, Senolytics look great, right? So therefore we should put dasatinib and quercetin in the drinking water of Houston and Rochester, and we will all, take over things in the long run. I agree. I don't think it's that simple. I think that in many ways, senescent cells in response to an injury are probably critical for transient adaptations of tissues in response to stress, right? So if you say, well, are we going to start treating patients when they're 30? If those patients are 30 years old, well, now when they're 70, are they going to end up having a less adapted myocardium? Are they going to be less resilient in response to a stressor, right? So what's that sweet spot, right? Where you want to be able to optimize adaptation, but at the same time, prevent pathobiological changes that accrue over time. I think we're, to be blunt, not close to that answer at this point. But I think when we're looking at the preclinical studies that need to be done, again, you're asking the exact right question, which is what is that clinical context and what's the clinical insight that's going to be needed to drive the appropriate preclinical studies? Because as John and I were talking last night, I mean, it's very, very easy to either run a trial that fails or run a trial that's positive and ultimately has a bunch of deleterious outcomes afterwards, right? And the history is filled with those. And so I think what we can't do is sort of live up to the statement that, the one thing that man learns from history is that man does not learn from history, right? And so how do we basically have a scientific clinical interface that really enables rapid, effective translation? And that's terrific. Those are the types of questions we need to be asking.
Well, I think we'll end there. Let's give Dr. Miller a hand.
Thank you very much. Fantastic. Thank you.